Welcome to the Deep Dive, the place where we take the most complex, source-heavy topics. The kind of material designed for true professional mastery, and we distill it into pure, actionable knowledge.
And today we are really getting into one of the most high-stakes areas in surgery.
We absolutely are. We're strapping in for a masterclass in surgical tissue survival, diving deep into the microscopic physics, the complex biomechanics, and the critical physiology that really determine the fate of a reconstructive skin flap.
When you look at this source material, you're looking at the foundational knowledge that elite reconstructive professionals have to rely on every single day. The difference between success and, well, catastrophic failure can often be measured in microns and milliseconds. It's that fine.
The level of precision it's almost humbling, And to set the tone for this entire deep dive, I want to start with a piece of wisdom from the great Sir Harold Gillies, who was really the pioneer of modern plastic surgery. He famously advised, make a plan and a pattern for this plan. And that single statement, I think, perfectly encapsulates our mission today. It's all about knowledge, precision, and preparation being the absolute cornerstone of successful tissue transfer.
That knowledge is everything because the core physiological challenge here is viability. When a skin flap is transferred, its initial survival just hinges completely on a robust, sustained blood supply that's delivered through its pedicle.
The attachment point.
The attachment point, exactly. Perfusion failure, so insufficient blood flow, that is the single greatest threat to survival. And it happens specifically before the body has time to develop new, collateral capillary networks. We really need to understand the biology and the physics to preempt that failure.
Okay, so before we jump into the history and the physics of flow, let's just make sure our language is precise for everyone listening. In this field, two terms get used constantly: skin flap and free flap. Can you just clearly distinguish between them for us?
Certainly. A standard skin flap is a block of tissue, and that might include skin, fat, fascia, muscle, even bone, that's surgically transferred from a donor site to a recipient site.
Okay.
The critical factor is that it maintains a continuous physical attachment to the body through a structure we call the pedicle. That pedicle is the intact vascular lifeline.
So the original blood supply stays connected the entire time.
Yeah.
What about the free flap then?
A free flap is an autologous tissue transfer, meaning it uses the patient's own tissue, but typically from a distant site. The key distinction here is that the pedicle is completely severed from the donor site.
Oh, completely detached.
Completely. The blood supply then has to be reinstated at the recipient site through this highly specialized precision surgery called microsurgical anastomoses. You are literally replumbing the artery and the vein of the donor tissue to the recipient vessels.
Wow.
And you're doing this using magnification, often operating on vessels that are less than 3 millimeters in diameter. It's incredibly delicate work.
Attached lifeline versus complete replumbing. Got it. So our mission today is ambitious. We're covering the history, the key anatomical discoveries, the physics that govern blood flow, common failure modes, and of course the cutting-edge rescue methods. We really want you to understand not just the what of these techniques, but the foundational why that dictates their survival.
Let's start at the beginning. It's a long and fascinating history. Tissue transfer is anything but new.
So setting that historical stage, even the term flap probably comes from the Dutch word flap, which, gives you this image of something broad and loose that hangs attached only at one side.
It's a very descriptive term.
It really is. It perfectly captures the simplicity of those early surgical attempts.
But the origins of structured reconstructive skin flap surgery, we owe a massive debt to ancient Indian Ayurvedic medical practice. We have to look back at the classical surgery textbook, the Sushruta Samhita,
which dates from around 600 BCE. Incredible.
It is. This text describes in really great detail the use of cheek flex specifically for nasal repair. The nose was often the site of, punishment or trauma, so it needed reconstruction, and they developed this sophisticated method for doing it.
That is just amazing. A standardized reconstructive procedure documented over 2.5 millennia ago. And it took until the late 18th century for this knowledge to be formally introduced to the West.
And that credit goes to an English surgeon, Joseph Carpue. He lived from 1764 to 1840. In 1794, he successfully introduced the Indian forehead rhinoplasty technique to the English language medical community.
Right.
He detailed the reconstruction of a bullock driver named Kawasji who had lost his nose. He took a segment of skin from the forehead, and it just illustrates how this practice bridged thousands of years of medical understanding.
So by the late 19th century, the focus starts to shift, right? It goes from just replicating techniques to a much more detailed scientific understanding, anatomical mapping.
Yeah.
And these seminal studies, they really laid the groundwork for modern flap design.
The first major mapping really came from Manshot in 1889. He published this groundbreaking work on distinct cutaneous vascular territories. He showed that specific, named arteries supplied very defined areas of the skin.
He was essentially drawing the first vascular roadmaps.
That's a perfect way to put it. These were the first detailed, reliable vascular maps that help surgeons predict which piece of skin could be safely moved based on its known arterial input.
And then his contemporary, Spalteholz, he added the dimension of depth to this map.
Yes, Spalteholz was key. He described the vessels that run through the fascia cutaneous vessels, and also those that pass directly through muscle. And this work established the foundational concept of the musculocutaneous blood supply.
Right, acknowledging that muscle and fascia are often critical links in the blood supply chain for the skin on top of them.
Exactly. And then you have Salmon in France, who added this crucial element of visualization that went way beyond just dissection.
This was technologically significant for the time.
Very. He injected intra-arterial contrast material into cadaver skin and then created radiographs. This allowed him to actually see the circulation in 3 dimensions and map the distribution of vessels in a way that dry dissection just couldn't achieve. It was a huge leap in our understanding of circulation patterns.
So now we fast forward into the 20th century, and the age of magnification just fundamentally changes the game. The ability to see and manipulate structures that are barely visible to the naked eye.
The first surgical microscope that was developed by Carl Olof Sigurdsson-Nylund, an ENT surgeon, back in 1921. But it was kind of confined to ear, nose, and throat and neurosurgery at first. The first modern operating microscope is credited to Zeiss in the 1950s.
And that technological leap is what enabled the precision you need to operate on these tiny blood vessels.
Absolutely. And this magnification immediately allowed for a better anatomically based classification of flaps. McGregor and Morgan in 1973 made a really pivotal distinction here.
This is where they separate axial and random pattern flaps.
Yes. For decades, there was this arbitrary rigid rule, often cited as the 3-to-1 length-to-width ratio for how far a flap could be safely extended. McGregor and Morgan used angiography and fluorescein injections to prove that this rule was, well, basically arbitrary for flaps that were built around a known, named axial vessel.
They showed that if a flap had its own direct central arterial highway, it could be far longer and more reliable than the standard random pattern flap that just relied on the general mesh of vessels.
Precisely. They introduced the paramedian forehead flap, which is a classic example of an axial pattern flap. But their most critical postulation was the concept of reverse flow in adjacent axial vessels.
Okay, what does that mean?
They theorized that if a main axial vessel was divided, the pressure drop would actually allow flow to be recruited from an adjacent connected territory, and this flow would come in the opposite or reverse direction to sustain the tissue.
So the system can reroute itself based on pressure. That concept of pressure-driven flow brings us to the ultimate cartography of the human body, angiosomes.
Yes, Taylor and Plummer took these concepts and gave them an enduring name. They coined the term angiosomes. These are composite blocks of tissue, 3-dimensional spatial units, and each one is reliably supplied by a specific source artery. This realization just fundamentally changed how surgeons planned tissue transfer.
And these blocks aren't isolated islands. They also defined how the adjacent territories connect to each other.
They connect in 2 main ways, either by true large-caliber anastomoses, or, more commonly, by these reduced-calibre vessels they called choke vessels.
Choke vessels.
And these choke vessels are the true demarcation lines. They define the maximum safe limit of a vascular territory. If a surgeon crosses a choke vessel without careful planning, the viability of the distal part of the flap is immediately in jeopardy.
They also noted that the accompanying veins were highly adaptable.
They named them oscillating veins because the flow in these venous structures could occur in any direction. It depended entirely on the local pressure gradient. This fluidity is a crucial protective mechanism against sudden congestion.
So while the classification of these attached or pedicled flaps was being refined, a far greater revolution was happening: the free flap.
The very first attempt at a free flap without microsurgical magnification was in 1959. Seidenberg and his colleagues used a free jejunal autograft, a segment of the small intestine, for a pharyngoesophagectomy reconstruction.
And the patient.
The patient survived for 8 days, and the graft was found to be viable upon his passing. But the technique, it just lacked the repeatability and sustainability that was needed.
So the breakthrough that made it a surgical reality was, again, the introduction of the microscope.
Indeed. The first successful, sustained free flap, as we recognize it today, was performed by Harry Bunk and Donald McLean in 1972. They used omentum, which is fatty tissue from the abdominal cavity, to reconstruct a large scalp defect with exposed bone, revascularizing it microsurgically. This was the proof of concept. It validated the technique and proved the viability of detached tissue transfer.
And that success immediately led to the hunt for new donor sites that minimized patient damage, which kicks off the perforator flap era.
Exactly. The question became, why harvest a large block of muscle if all you really need is the skin and the fat on top? The focus shifted to using vessels that perforate or pass through the muscle or fascia just to supply the skin.
A much more elegant solution.
A much more elegant solution. This era officially began in 1989 with Koshima and Soeda. They used the inferior epigastric artery skin flap for reconstructing complex defects. This was a monumental leap forward in minimizing donor site morbidity. You're only taking what is absolutely needed for the reconstruction.
So if we bring all this history into the present, how do we classify the modern landscape of flaps?
Modern flaps are primarily divided into pedicled flaps, which retain their attachment, and free flaps, which are detached and replumbed. The pedicled flaps are then subdivided by their dominant blood supply. So you have random arterial cutaneous, which is axial, fasciocutaneous, musculocutaneous, and venous flaps.
And the free flap subdivisions.
They're defined by what tissue they contain. So fasciocutaneous, musculocutaneous, osteocutaneous, that's bone and skin, or purely muscular. But the highest level of complexity today is what we call the chimeric free flap.
The mythical creature made of combined tissues.
Precisely. A chimeric free flap uses combinations of different tissue types, say muscle, bone, and skin, all supplied by separate branches that originate from a single main pedicle. This allows for incredibly complex, simultaneous, three-dimensional reconstruction of massive defects, all in a single procedure.
It's an incredible journey from ancient Ayurvedic practice to these high-tech chimeric flaps. Looking forward, what are the next frontiers for non-oncological reconstruction?
Our sources really point to two main areas that hold significant promise. The first is allotransplantation. This involves transferring tissue between genetically non-identical individuals, which you see in complex procedures like full facial or hand transplants.
Right.
The second is tissue engineering, which involves growing complex tissue like cartilage or vascularized skin constructs in a laboratory environment for later surgical implantation.
That history gives us the context. Now, let's get specific about the material itself. Skin, the body's largest organ, is the foundation of our work here.
The skin is our essential boundary organ. It's remarkably robust, weighing about 3.8 kilograms and covering roughly 1.7 square meters in an adult. Beyond just being a physical barrier, it's impermeable, it's constantly renewing, it's metabolically active, and it provides crucial sensory input and, most importantly, for our topic protective functions against physical insult and infection.
Let's break down the microstructure, starting with the most superficial layer, the epidermis.
The epidermis is a multi-layered keratinizing squamous epithelium. Its main cell type is the keratinocyte, but it also contains melanocytes for pigmentation, Langerhans cells for the immune response, and Merkel cells for sensation.
Okay.
Critically, the epidermis and all its appendages, so hair follicles, sebaceous glands, sweat glands, they are all of ectodermic origin. And the whole thing renews itself through the asymmetric division of interfollicular stem cells located in the deepest layer, the stratum basal. It's a completely self-renewing barrier.
And beneath that, we have the thick structural layer, the dermis.
The dermis is derived from the mesoderm, and it forms the bulk of the skin. It's typically 15 to 40 times thicker than the epidermis. It's essentially a resilient connective tissue layer that houses the structural integrity and all the vital infrastructure, the nervous tissue, the vascular networks, and the epidermal appendages.
And what gives the dermis its distinctive pliability, its elasticity, and tensile strength? I mean, these are the properties that allow us to move flaps around.
That comes down to the extracellular matrix, which is synthesized primarily by cells called fibroblasts. This matrix is abundant in collagen type 1, which provides the tensile strength, and collagen type 3, which gives it pliability, along with elastin fibers, which provide the recoil, the snapback.
Right.
These fibers are all embedded in a ground substance matrix of proteoglycans and glycosaminoglycans, and those contribute to the tissue's more viscous, gel-like properties.
We could subdivide the dermis into two layers, can't we?
Yes, the superficial layer is the papillary dermis. It has this distinct waveform pattern because of the reed pegs interdigitating with the epidermis. The deeper, thicker layer is the reticular dermis, and these layers are functionally distinct, particularly when you look at their vascular networks.
Let's detail that vasculature because this is the lifeline. The first critical network is in that superficial layer.
That's the capillary network located high up in the papillary dermis. These vessels are extremely fine, only about 10 to 20 microns in diameter. Their function is purely nutritional. They provide the essential support needed for the avascular epidermis to survive.
And the second network, deeper down, is where the body handles its regulatory duties.
Deeper, in the reticular dermis, we find these abundant arteriovenous shunts. These vessels are a bit larger, 10 to 30 microns in diameter, and they are designed to bypass the capillary beds entirely. Their existence is crucial because their primary role isn't nutrition, it's rapid thermoregulation and assisting in systemic blood pressure control.
That makes so much sense. That explains why the skin is so vastly overperfused compared to its actual metabolic needs.
Exactly. Under normal, non-stress conditions, the skin gets about 9 milliliters of blood flow per minute per 100 grams of tissue. That is 10 times the minimum metabolic requirement just to keep the skin alive. The bulk of that excess flow capability is reserved for thermal control.
How dynamic is that thermal response?
Extremely dynamic. In a hot environment with maximal vasodilation, blood flow can increase up to 20 times the baseline rate. The body is effectively using the skin as a radiator to dump heat.
And the opposite in the cold.
Conversely, in extreme cold or during systemic shock, flow can be reduced to marginal levels, just enough for baseline survival to conserve core body heat.
And this rapid control is achieved via those two sphincter types you mentioned earlier.
Yes. The nutritional flow is controlled by the precapillary muscles. These are smooth muscle rings that regulate flow into the capillaries. These sphincters dilate primarily in response to local signals like skin hypoxia and metabolic byproducts, making sure the tissue gets fed when oxygen levels drop.
And the regulatory flow, the shunting.
That is controlled by the pre-shunt sphincters. These regulate flow through the arteriovenous shunts. They're activated by the sympathetic nervous system, primarily through the release of norepinephrine or by systemic catecholamines during generalized stress.
So when the body's under pressure.
Right. When the body faces low systemic blood pressure or extreme cold, the skin is treated as a non-vital organ. These sphincters contract, shutting down flow through the shunts and diverting that precious blood to the core organs.
So the survival of the flap is literally fighting against the body's own centralized survival-based decision to divert blood elsewhere in an emergency.
That is the core conflict right there. The flap needs maximum uninterrupted flow, but the body's systemic priority is the survival of the brain and the heart.
We've established the structure. Now let's apply that geographical map of blood supply, returning to the angiosome concept from Taylor and Palmer. This knowledge is the plan and pattern that Sir Harold Gillies was talking about.
Understanding the angiosome, that spatial pattern of blood supply fed by a specific artery, is absolutely non-negotiable for flap design. Let's focus on the head and neck, which is a region with particularly complex and vital reconstructive needs.
Okay, so our sources break down the head and neck into 13 distinct angiosomes. What are the key arteries that are feeding this region?
The head and neck angiosomes are primarily supplied by branches of the external carotid artery, the internal carotid artery, and the subclavian artery. Now, out of those 13 territories, 10 are crucial for us because they contribute extensively to that robust subdermal vascular network that actually sustains a skin flap.
And it's essential to remember the 3 exceptions, the territories that feed deeper structures but basically bypass the skin.
Correct. The 3 angiosomes that do not significantly reach the skin surface are the vertebral angiosome, the ascending pharyngeal angiosome, and the lingual angiosome. So a surgeon designing a skin flap cannot rely on blood supply originating from these deep arteries.
Considering the skin density in this area, what does the perforator map look like?
The head and neck is the smallest regional area of the body, yet it's incredibly rich in these small vessels. It contains about 25 perforators. Those are vessels that breach the deep fascia or muscle that are greater than 0.5 millimeter in diameter.
That's a lot.
It is. On average, a single perforator in this region is about 0.9 millimeters in diameter, and it irrigates a territory of about 32 square centimeters. It's a highly interconnected system.
That high interconnection leads us perfectly to the evolution of this concept, the perforasome.
Right. The term perforasum was coined by Saint-Cyr and his colleagues in 2009. They used some cutting-edge technology, static and dynamic computed tomographic angiography, or CTA, in cadaver studies, to define the specific vascular territory nourished by just a single perforator. Their findings really revolutionized the precision of flap design and gave us four key clinical conclusions.
Okay, let's analyze the first conclusion, which relates to multidirectional flow and inherent protection.
The research confirmed that each perforasum doesn't just have a simple fixed flow line. It has a highly variable, complex, multidirectional flow pattern. This perforasum territory is interconnected to its adjacent territories by both direct and indirect linking vessels.
So the body builds in redundancy.
It builds in redundancy. This extensive redundant network is what provides this intrinsic protection against localized vascular injury or ischemia during the meticulous process of raising the flap.
That makes sense. The second finding concerned the orientation of these linking vessels.
And the second conclusion was highly practical. The linking vessels run parallel to the principal direction of the perforator flow. The immediate clinical consequence is for flap design, especially for very large flaps, like the extended anterolateral thigh flap.
So you design the flap to follow that flow?
You design the skin paddle to be parallel to this established linking vessel orientation. This maximizes the flow you can capture from adjacent territories and allows for maximal length.
This leads to the most fascinating dynamic observation, the third conclusion. Hyperperfusion and recruitment. How does the very act of harvesting a flap, which involves cutting vessels, actually lead to better flow pressure in the chosen pedicle?
This is the elegant mechanism that makes perforator flaps so viable. When the surgeon isolates the desired perforator, they intentionally ligate or tie off all the surrounding muscle, fascia, and cutaneous branches that would normally be sharing the flow.
Okay.
This diversion of blood flow causes a dramatic and immediate increase in the vascular filling pressures within that one selected perforator. It is forced into a state of hyperperfusion.
So that pressure spike then forces the entire system to expand.
Exactly. This elevated pressure clinically dilates the main perforator itself, increasing its internal volume capacity. And crucially, this hyperperfusion actively recruits additional linking vessels that were previously choked down. The increased pressure forces these linking vessels open,
Allowing the flap to capture the territories of the vessels that were just tied off.
You've got it. It allows the flap to effectively capture the vascular territories, the perforasomes of the adjacent, now ligated perforators. The resulting flap is much larger than the territory of the single chosen perforator, and this is a phenomenon enabled purely by fluid dynamics and pressure.
That is a direct application of fluid dynamics to achieve a larger surgical outcome. It fulfills Gillies' need for precision. Now, the final conclusion deals with flow direction, showing the map isn't universal, but context-dependent in the extremities.
Yes, the fourth conclusion showed how location determines flow direction near articulations, or joints. Perforators that are situated near joints exhibit a unidirectional flow pattern. Their flow preferentially moves away from the joint.
For example,
the perforators in the distal forearm near the wrist will typically flow toward the proximal elbow.
and what about the areas midway between joints?
Perforators located midway between two articulations, like in the mid-calf, have a bidirectional flow pattern. They're capable of sending blood towards both the knee and the ankle. Understanding this directionality, unidirectional versus bidirectional, is vital for determining the optimal orientation and maximal length when you're harvesting a flap from an extremity.
We've detailed the anatomy. Now we have to confront the unforgiving laws of physics.
Mm-hmm.
Flap survival is entirely dependent on blood flow, which we'll call collars. This entire next section breaks down that fundamental relationship between pressure, resistance, and the microscopic dimensions of the vessel.
We have to approach this like engineers. The most fundamental relationship is that flow equals pressure difference divided by resistance. So, Q equals delta over torolars. Flow is directly proportional to the pressure gradient and inversely proportional to the resistance produced by the vessel itself.
And for these calculations, we're relying on the assumption of laminar flow.
Laminar flow is the ideal state. The fluid moves in these concentric layers, or laminae, fastest in the center and slowest near the wall. But the moment you introduce turbulence, maybe from an angulation of the vessel, branching, or an obstruction like a thrombus, that flow pattern breaks down.
Right.
The movement of molecules across the flow direction dramatically increases the resistance, $2, making it exponentially harder to push blood forward.
And this brings us to Poiseuille's law, which explains why surgeons must prioritize the diameter of the vessel above almost all else. We really need to explain the formal relationship for resistance.
Oh, Poiseuille's law? when applied to resistance, states that $3 is directly proportional to the fluid viscosity, which is eta, and the length of the vessel, $3. But the most critical term is the radius, 3. Resistance is inversely proportional to the fourth power of the radius.
Okay, let's say that again.
The formula is $3 equals 8 eta divided by pi to the power of 4.
The inverse fourth power rule, if you are listening, you have to internalize what that means clinically. If a vessel spasms or it constricts because of cold and its radius is reduced by just half, say, from 2 millimeters to 1 millimeter, the resistance doesn't just double or quadruple. It increases by a factor of 16.
Let's use an analogy. Imagine you're trying to use a fire hose to water your garden. If you use a regular-sized hose, that's a large radius, you get a massive flow, a massive Q dollars. Now imagine trying to use a tiny coffee stirrer to carry that same amount of water from the hydrant to the garden. The pressure needed to overcome the astronomical resistance in that tiny straw is impossible to achieve. That's your factor of 16 increase in resistance. This principle is why a minor vasospasm in a microvascular anastomosis can instantly cause a flap to fail.
Wow. Now, what about the viscosity component, Ada? Our sources note that in the microcirculation, viscosity behaves, well, kind of counterintuitively.
This is the Farays-Lindquist effect. In vessels that are narrower than 1.5 millimeters, the viscosity of blood actually decreases significantly. In capillaries, it can be half that of blood in larger vessels. This is a crucial physiological advantage.
How does the body achieve that reduction?
It's explained by Bloch's postulate. Red blood cells, which are the main source of blood viscosity, they tend to congregate in the center of the flow stream. This creates a marginal layer of plasma, a cell-free zone right near the vessel wall. And since this marginal layer, which is the layer contacting the vessel wall, has fewer cells, its viscosity is naturally lower. This lowers the resistance in these small vessels and helps the flow. In the tiniest capillaries, red cells even have to deform into single file, changing shape from discs to paraboloids, which further minimizes frictional resistance.
So the body is using physical principles to fight the resistance in its smallest structures. But resistance isn't the only threat. External tension or wall tension can cause the vessel to collapse. This is where Laplace's law comes in.
Laplace's law explains the relationship between tension and pressure in a circular structure like a blood vessel. It states that the tangential vessel wall tension, which we'll call $2, is proportional to the vessel diameter multiplied by the pressure across the vessel wall, so $2 is proportional to $1 times $2.
And the concept that follows from this is the critical closure pressure.
This is the danger point. The critical closure pressure is the transmural pressure, the pressure difference across the vessel wall at which the elastic tension in the vessel wall exceeds the internal pressure. When that happens, the vessel snaps shut, even if the flow upstream is perfect.
And the clinical implications of that are immediate and severe.
Any factor that increases wall tension or decreases internal pressure makes the vessel susceptible to collapse. Increased resting tone in the vessel, vasospasm, reduces the radius and increases wall tension vulnerability. Even more common. Severe flap edema or a developing hematoma increases the interstitial pressure outside the vessel. If this external pressure rises above the critical closure pressure, it just compresses the vessels from the outside, resulting in total flow occlusion.
Which explains why the distal edges of a flap, fed by the smallest, lowest pressure vessels, are always the first to fail. And this deep dive into physics brings us back to Milton's famous 1970 finding, what we call the length-to-width fallacy. It directly challenges that historical length-to-width ratio.
Milton's statement was stark. The surviving length of flaps made under similar conditions of blood supply is constant regardless of width. This was highly counterintuitive at the time. Surgeons believed a wider cut was a safer cut.
So why does simply increasing the width not extend the survival lengths? Let's break down the clinical takeaway here.
We have to link this directly back to Laplace's law and the pressure gradient. The survival length is dictated by the point where perfusion pressure drops below the critical closing pressure in the capillaries. If you picture the pressure dropping over the length of the flap, the slope of that pressure decrease is determined by the size and resistance of the main feeding vessels and the vascular network itself.
So increasing the width, say from a narrow flap A to a wider flap B, it might incorporate a few more vessels and momentarily increase the initial pressure.
But it does not fundamentally change the rate at which that pressure drops per centimeter of length. The fixed length at which the pressure hits that critical closing point remains the same.
The clinical implication is enormous. A surgeon wasting time creating a wider flap to adhere to some arbitrary ratio is only increasing the donor site morbidity and complication risk without providing any additional gain in safe length.
Mastery requires prioritizing the anatomical axial supply and the pressure gradient, not just the volume of included tissue.
We've looked at the flow inside the vessels.
Yeah.
Now let's look at the properties of the container itself, the skin tissue. This segment is all about skin biomechanics.
We have to see skin as a complex engineering material. It's a composite with 3 defining properties. It's viscoelastic, nonlinear, and anisotropic. And these properties dictate how the skin responds to the stretching and manipulation that's inherent in moving a flap.
Let's start with nonlinearity. This is best visualized by the stress-strain curve, how resistance changes as you stretch the skin.
The nonlinear behavior is absolutely crucial for survival. When you apply stress, which is force, and you measure the resulting strain, or deformation, you see 3 predictable phases.
Okay, phase 1 is the toe region.
In the toe region, the skin offers very little resistance. It feels malleable, it stretches easily. This is because the collagen fibers within the matrix start off highly crimped and disorganized. The initial application of force is just straightening and aligning these fibers along the direction of the stress.
Then we hit phase 2, the intermediate phase.
The curve steepens dramatically here. It requires significantly more stress to achieve further lengthening. And this happens because more and more of the collagen fibers, which are now straightened, are recruited into a load-carrying role. They begin to actively resist the force.
And phase 3 is the point of maximal danger during closure.
Phase 3 demonstrates almost complete rigidity. All the collagen fibers have been deployed. They're all bearing the maximal load. The skin resists further deformation almost completely, regardless of the massive increase in force applied. This structural resistance is designed to protect the integrity of the tissue, to prevent it from tearing.
And how does age affect this curve?
Aged skin is typically less malleable initially. The curve is shifted a bit along the strain axis. This is due to a reduction in the density and quality of the elastic fibers. However, if you look at the curve under maximal force, the young and aged curves coincide in phase 3. This means both young and old skin demonstrate the same high resistance and refractoriness at maximal stretch.
And the clinical danger of pushing a flap into that phase 3 rigidity.
It leads directly to vascular compromise. That excessive flap tension, which causes a lack of deformation at high forces, it compresses the small caliber peripheral vessels exactly where the pressure is lowest, thanks to Laplace's law. If you force the closure, you are guaranteeing distal flap necrosis due to external compression. It completely violates Gillies' principle by failing to plan for the tissue's physical limitations.
Next, let's define anisotropy.
Anisotropy simply means directional qualities. Skin is not uniformly strong in every direction. The tension is greatest along the relaxed skin tension lines, or RSTL. These lines, originally called Langer's lines, represent the natural orientation of the collagen bundles in the dermis.
And incisions made perpendicular to those lines cause problems.
They result in massive, wide, gaping wounds that require very high tension for closure. This severely impacts scarring and, more importantly for us, it compromises flap survival.
The third property, viscoelasticity, is the one that surgeons intentionally exploit.
Viscoelasticity describes a material that exhibits both viscous, so fluid-like, and elastic, so solid-like characteristics. It's defined by 2 key phenomena: creep and stress relaxation.
Define creep for us first.
Creep is the increase in strain or progressive lengthening that you observe when a sudden, constant load is applied to the skin. The skin fibers slowly reorganize and stretch over time, even though the force being applied isn't increasing.
And stress relaxation.
Stress relaxation is the converse. It's the decrease in stress or the force required to maintain a specific length when the skin is held at a constant stretch length. The internal resistance of the tissue actually decreases over time.
This sounds like the principle behind tissue expansion.
It is the governing principle. Viscoelasticity is what allows surgeons to use techniques like tissue expansion, where a constant volume applies a constant stretch, and also serial sections, allowing the skin to gradually yield. These techniques allow you to recruit vast amounts of skin that would be impossible to mobilize in one go.
And engineers are now quantifying these limits using sophisticated software. Tell us about finite element analysis, or FEA.
FEA is a computational technique used to model complex physical bodies by dividing them into these small interlocking elements, the finite elements, to simulate stress, strain, and displacement. Lovold and his colleagues applied FEA to a monopedicle advancement flap model. Their objective was to provide hard, quantifiable limits for surgical planning.
What was their key conclusion regarding safe limits?
Based on their modeling, they concluded that to minimize harmful deformation and maintain a low-tension closure, the advancement flap length should not exceed 3 times the size of the defect it is designed to close. This is a crucial biomechanical limit derived from computation, and it adds mathematical rigor to Gillies' call for planning.
We've planned the pattern, we've understood the physics, and respected the tissue limits. But even so, flaps fail. This next segment focuses on recognizing and managing the compromised flap.
We have to reinforce Sir Harold Gillies' 15th principle here. The aftercare is as important as the planning. He urged surgeons to get their hands out of their pockets and investigate immediately if there was any doubt about circulation. Failure to recognize compromised circulation promptly is, statistically, the most common single cause of flap loss.
Let's look at the cold, hard data. The Pollen study of 1,000 free flaps confirmed the epidemiology of failure.
Yes, that retrospective review of microvascular free flaps transplanted in the head and neck showed that vascular occlusion, or thrombosis, was the primary reason for flap loss. Arterial occlusion occurred in about 4.5% of cases, but venous occlusion was significantly more common at 6.8%.
And most of these failures happen quickly.
Very quickly. The majority occurred within the first 36 hours post-operation. If the flap can survive the first 2 days, its prognosis improves dramatically.
So the most likely threat is blood getting in but not being able to get out. Let's look at the extrinsic factors that cause this compression.
Extrinsic factors are those external compression forces. They can include an overly tight dressing or bandage, excessive tension during the final wound closure, especially if the flap is draped over a rigid bony surface, and, most commonly, soft tissue swelling or a developing hematoma, a collection of clotted blood.
What's the classic clinical presentation of this kind of extrinsic failure?
The flap will typically appear dusky, blue, and engorged. It's suffering from venous congestion. Blood is arriving via the low-pressure arterial system, but the external pressure is collapsing the already lower-pressure venous outflow system, causing a backlog.
So the immediate management is mechanical and swift.
Absolutely. Prompt release of all restricting bandages, removal of sutures in the vicinity, or immediate drainage of the hematoma. We have to adhere to the adage. It is better to have a live flap out of position than a dead flap in position. You must relieve that pressure immediately.
But the sources detail that a hematoma causes injury far beyond just simple pedicle compression. There's complex and devastating biochemical injury, even from distant, uncompressing hematomas.
This understanding comes from research by Glass and his colleagues. The hematoma sets off this vicious inflammatory cascade. Degraded platelets release powerful cytokines, which act as beacons, attracting massive numbers of neutrophils, the body's innate immune cells, to the site.
And the neutrophils, which are just trying to clean up, actually initiate the tissue damage.
They do. The neutrophils release huge amounts of reactive oxygen species, or ROS. You can think of ROS as molecular shrapnel. These highly reactive chemical species cause direct oxidative damage to the delicate tissue components, and that's what initiates the injury.
And the cascade just keeps accelerating from there.
It does. Thrombin, which is released during the clotting process, triggers the complement cascade, which amplifies the inflammation. Even worse, the ferrous ions released from the degradation of hemoglobin as the red blood cells lyse act as potent catalysts, promoting the generation of further ROS.
So the original clot creates an environment of molecular shrapnel, inflammation, and cellular breakdown.
The combined effect is endothelial cell disruption, damaging the lining of the blood vessels, which then activates the prothrombotic pathways, leading to small vessel occlusion and local tissue ischemia. And this ischemia, in turn, generates more ROS, creating a self-perpetuating, non-stop cycle of injury that rapidly destroys the flap from the inside out.
Beyond mechanical and localized biochemical failure, we have intrinsic factors, the patient's existing comorbidities. And these patients are often elderly cancer patients with complex medical histories.
These patients frequently present with a whole constellation of issues: long-term smoking and alcohol use, underlying myocardial ischemia, peripheral vascular disease, diabetes mellitus, cachexia, chronic anemia. All these factors compromise the already fragile microcirculation.
Is age itself an intrinsic risk factor for free flap failure?
Surprisingly, the data here is encouraging. The study by Yang and his colleagues on head and neck cancer patients over 80 undergoing free flap reconstruction reported 0 flap failures or perioperative deaths. Age, provided the patient is otherwise optimized, is not independently an aggravating factor for flap survival.
However, diabetes mellitus is clearly a massive intrinsic factor.
The systematic review by Rosado and colleagues confirmed this. They found that the incidence of diabetes mellitus in patients experiencing failed free flaps was 2.3 times higher than in the general population. The likely mechanism is that the pre-existing microvascular disease in diabetic patients eliminates the body's redundancy and its ability to recruit choke vessels, making the flap far more susceptible to failure.
Finally, let's detail the microscopic failure itself, the vascular cascade, starting with vasospasm.
Vasospasm is a normal initial physiological response after the flap is raised. It's intended to reduce immediate blood loss. Under ideal conditions, this spasm is transient and resolves naturally. The presence of an intact endothelium is vital here, as it prevents the coagulation cascade from kicking off inside the vessel.
But if ischemia is prolonged, we can reach the point of no return, the no reflow phenomenon.
This was coined by Ames and colleagues back in 1968. It describes the irreversible failure of tissue to reperfuse after several hours of ischemia. Even if the surgeon mechanically clears a clot and physically reopens the vessel, flow cannot be reestablished in the microvasculature.
And this mechanism loops us right back to the reactive oxygen species.
The mechanism is tied directly to reperfusion injury. When blood is reintroduced, it generates a massive burst of oxygen-derived free radicals. This damages the endothelial cells, which are critical for smooth flow. The damaged endothelium can no longer produce and release nitric oxide, or NO, which is the body's essential local vasodilator.
So the loss of nitric oxide shifts the balance toward constriction.
Precisely. Without NO, the system defaults to vasoconstriction. The damaged endothelium can no longer mediate the necessary vasodilator effect, leading to localized vasoconstriction and sustained failure to reestablish flow in the smallest vessels, even with adequate pressure arriving from upstream.
The role of nitric oxide is so central here that our sources mention gene studies around the inducible nitric oxide synthase, or INOS.
This is elegant basic science. Studies using INOS knockout mice genetically engineered to lack the inducible form of the enzyme showed that the activity of this specific NO synthase actually promotes the survival of ischemic tissue. In fact, administering an INOS inhibitor increased flap survival in these models. It confirms that sufficient NO production is essential for managing blood flow and reducing the devastating effects of ischemia reperfusion injury by keeping the microvasculature open.
We've meticulously mapped the problem. Physics, anatomy, and biochemistry are all working against the compromised flap. This final segment details the aggressive pharmacological and physical interventions used to rescue or condition the tissue for survival.
Given the massive role of reactive oxygen species in failure, the initial pharmacological approach focused heavily on finding effective free radical scavengers.
What are some of the early targets?
Superoxide dismutase, or SOD, an enzyme designed to disarm ROS, showed promising improvement in animal flap survival. But unfortunately, these results just failed to translate into reliable clinical benefit in human trials. Another major target was the iron chelator deferoxamine, or DFO. Since those ferrous ions from hemoglobin accelerate ROS generation, DFO, by binding that iron, successfully reduced free radical involvement in experimental flap surgery.
But DFO had significant toxicity issues. How was that addressed?
To mitigate the systemic toxicity and improve its half-life, researchers developed a conjugated form, deferoxamine hespan, or DFOH, which was tested in pigs. While it was successful in increasing the half-life, its conjugation unfortunately hampered its ability to penetrate cell membranes and reach the crucial intracellular oxygen-free radicals, so that reduced its efficacy in the clinical setting.
And a third scavenger, allopurinol, also showed experimental promise.
Yes, allopurinol is a xanthine oxidase inhibitor. Xanthine oxidase levels are elevated in ischemic tissue, and they contribute to ROS generation. Inhibiting this enzyme augmented flap survival in animal models. But despite the logical mechanism, a definitive, reproducible clinical benefit in human flap salvage has yet to be convincingly established. It's frustrating that transition from bench to bench. Endothelin-1, or ET1, is an incredibly potent endogenous peptide. It's produced specifically in ischemic tissue, and its levels become highly elevated immediately after reperfusion. Human studies on breast reconstruction flaps confirmed a statistically significant increase in ET1 levels post-clamping the pedicle. It is a massive force working against flap survival.
So how did researchers address this powerful, localized vasoconstrictor?
By utilizing receptor blockade. Studies, particularly in pig TRAM flaps, showed that tezacentan, an endothelin receptor blocker, significantly improved oxygenation and metabolism in the jeopardized flap tissue.
And here is the critical clinical connection back to the epidemiology we discussed. Venous failure is more common than arterial failure.
Tezacentan's beneficial effect was specifically attributed to a decrease in venous vascular resistance. This finding strongly supports the observation that the vasoconstrictor potency of ET1 is significantly higher in the venous system than in the arterial system. It has a maximal venous effect, so blocking ET1 selectively and powerfully targets the most common failure mode, venous congestion.
Moving to simple, smooth muscle relaxants. What is the role of calcium channel blockers?
Calcium channel blockers like nifedipine and verapamil are direct, smooth muscle relaxants that have been shown to increase flap survival in animal models by promoting vasodilation. However, their clinical use in humans is largely restricted. They're typically applied topically directly onto the site of microvascular anastomoses to locally relieve spasm, as widespread systemic use for flap salvage just lacks supportive trial evidence.
And regarding topical vasodilators, what agents are used in clinical practice?
Topical nitroglycerin, or GTN, is commonly used. Like the endothelin blockers, GTN exerts a greater vasodilatory effect on the venous circulation, helping to alleviate that venous congestion. It's used clinically with variable success rates. Interestingly, intraoperative systemic vasopressors, used to maintain blood pressure, are generally considered safe during free flap surgery, as the benefits of adequate systemic pressure usually outweigh the peripheral vasoconstrictive effects.
But only one substance has been definitively supported by a randomized controlled trial for reducing human flap ischemia.
That is dimethyl sulfoxide, or DMSO. The trial by Ranluby and colleagues on human mastectomy skin flaps demonstrated that topical application of DMSO safely reduced the incidence and extent of flap ischemia. It remains one of the few high-level evidence-supported pharmacological agents for this purpose.
Let's revisit the role of inflammation. What agents aim to inhibit that damaging neutrophil recruitment process?
Inhibiting neutrophil invasion is a major focus, as that surgically induced recruitment impairs flap survival. Agents like calcitonin gene-related peptide, or CGRP, and sulfatide, a compound that binds to the receptors L and P-selectin, blocking neutrophil adherence, have been shown in animal models to reduce neutrophil invasion and myeloperoxidase activity, leading to improved flap survival.
And what about blocking platelet activity, addressing the other major component of thrombosis?
The platelet glycoprotein a receptor antagonist, abciximab, has shown great promise. By blocking the final common pathway of platelet activation and aggregation, abciximab significantly promoted experimental skin flap survival, especially after prolonged ischemic periods. This suggests it has a role in mitigating reperfusion injury.
Stepping into the future, we have the ultimate pharmacological intervention: gene therapy. What did early research show regarding vascular endothelial factor, or VEGF?
Exogenous VEGF, administered via gene therapy, specifically using adenovirus vectors, has shown remarkable results in rat models. VEGF is a powerful regulator. It protected flaps from ischemia-reperfusion injury primarily by regulating pro-inflammatory cytokines and inhibiting cytotoxic nitric oxide production. While it can promote new vessel growth, its immediate benefit is reducing the size of the necrotic and hypoxic zones, though clinical application is still an emerging area.
And finally, what about conventional anticoagulants like destrin and heparin?
While they are essential for ensuring the patency of microvascular anastomoses in experimental settings, dextrin and heparin have not been reliably shown to be effective in rescuing an already failing flap. They can help prevent clotting, but they don't reverse the underlying physiological problems of vasospasm or critical closure.
Let's pivot to the physical and mechanical conditioning methods, which are often safer and more reliably established than pharmacology. The first is surgical delay.
Surgical delay is perhaps the most well-established physical intervention. It involves a surgical procedure that intentionally renders a flap partially ischemic several days prior to its final transfer. This controlled injury conditions the tissue to survive the final, more stressful transfer.
What's the proven mechanism behind this conditioning? Why does it work?
The key research from Dar and Taylor showed that surgical delay is not due to the growth of new vessels. Instead, the temporary ischemia causes dilation and enlargement, so hyperplasia and hypertrophy, of the existing choke vessels that connect the vascular territories. The tissue adapts by making its existing bloodlines bigger and stronger.
And tissue expansion utilizes this same principle.
Correct. Tissue expansion can be considered a controlled form of surgical delay. Studies on porcine flaps showed that expanded tissue survived 150% greater lengths compared to acute, non-delayed flaps. This increased survival length was confirmed by angiography, showing a measurable increase in the caliber of the axial vessels. It allows the surgeon to recruit massive amounts of conditioned skin.
The cutting edge of physical conditioning involves applying brief cycles of sublethal ischemia and reperfusion.
This is tissue conditioning. Ischemic preconditioning, first described in 1986, applies brief, non-damaging cycles of ischemia before the definitive surgical injury to trigger protective cellular pathways. Then there's ischemic post-conditioning, introduced in 2003, which applies those cycles after reperfusion starts to mitigate the damage caused by the sudden reintroduction of oxygen in ROS.
And the truly elegant version is remote ischemic conditioning, or RIC.
RIC leverages a systemic protective response. You apply those brief, sublethal ischemic cycles to a distant, easily accessed site, say, the patient's arm or leg, to protect the target tissue, like a flap being harvested from the thigh. RIC has been proven to significantly increase tissue oxygen saturation and capillary blood flow in the target site, demonstrating that the body can launch a protective response across different vascular territories.
In severe trauma or vessel-depleted operative fields, sometimes surgeons need external assistance to maintain viability. That brings us to extracorporeal perfusion, or ECP.
ECP is a pump-assisted technique used to revascularize severed limbs or free flaps, buying crucial time and reducing the effects of prolonged ischemia. Our sources cite a fascinating case report of a young boy with chondroblastic osteosarcoma whose amputated leg was placed on an ECMO, extracorporeal membrane oxygenation, for 162 minutes, while the surgeon simultaneously utilized tissue from that limb to reconstruct the remaining segment.
Incredible.
It's also being used in vessel-depleted neck cases, demonstrating successful free flap transfers under ECP, which significantly reduces the duration of cold ischemia.
Finally, we arrive at two extremes, one high-tech and one ancient. First, lasers.
Low-energy helium-neon laser irradiation has been shown to improve viability in compromised tissue. This is attributed to a subtle boost in the tissue's own defenses, specifically improved superoxide dismutase activity and enhanced cell proliferation. It's a non-invasive way to optimize cellular function.
And the final critical intervention for pure venous congestion, the medical leech, Hirudo medicinalis.
Yes, the use of leeches persists specifically for congested microvascular flaps where venous outflow is compromised and surgical revision just isn't possible. The leech injects a cocktail of bioactive compounds, hirudin, a powerful natural anticoagulant, hyaluronidase, and a potent vasodilator. This prolongs bleeding at the site and physically relieves the life-threatening venous congestion.
But there's a massive clinical risk that must be addressed whenever leeches are used.
Absolutely essential. Antibiotic cover must be provided immediately and routinely. The leech's gut harbors the enteric organism, Aeromonas hydrophila, which poses a serious, life-threatening risk of secondary infection. Failure to administer antibiotics can easily lead to sepsis and the definitive loss of the flap. The ancient technique must be managed with modern microbiology.
We have journeyed from the anatomical maps of the late 19th century all the way to the biomechanical limits defined by modern computation. Let's quickly summarize the core concepts that you, the listener, should take away for true mastery.
First, the anatomy is your plan. Recognize that the skin is a complex organ dedicated to thermoregulation, making it highly susceptible to systemic priorities. Your surgical plan must be based on the map of vascular territories, the angiosomes and perforasomes, to ensure flow.
Second, you must respect the physics. Internalize the meaning of Laplace's law and the critical closure pressure. And remember the exponential danger posed by Poiseuille's derived resistance relationship. That resistance is inversely proportional to the fourth power of the radius. Small changes in diameter create massive, detrimental changes in flow.
Third, acknowledge the failure modes. The flap is most vulnerable in the first 36 hours. Failure is often extrinsic hematoma or a tight closure, and intrinsically linked to comorbidities like diabetes. Be prepared to immediately intervene against the devastating biochemical cascade triggered by the no-reflow phenomenon.
And finally, know the solutions. Surgical delay, tissue expansion, and remote ischemic conditioning are proven physical methods to strengthen existing vessels. Pharmacological research continues to target ROS damage and reverse the highly potent endothelin-1-mediated venous vasospasm.
Our journey began with the precision required by Sir Harold Gillies. Make a plan and a pattern for this plan. We've seen that plan evolve from crude skin cuts to microvascular anastomosis, defined by mathematical limits and biological conditioning.
As we close this deep dive, consider the profound interplay between those microscopic physical forces, like the wall tension in Laplace's law dictating vessel collapse, and the massive biological outcome that results. The difference between life and necrosis for a transferred block of tissue. It is the ultimate fusion of engineering and biology.
Thank you for joining us on this deep dive into skin flap physiology. We hope this knowledge serves you well in all your future endeavors.
See you next time.